Hello, everyone. We're going to give individuals just a few more minutes to join before we get started here. Hello, everyone. My name is Bobby Fredrickson, and I'm the Senior Growth Lead for Physician Groups here at Patient Ping. I'm thrilled to welcome you all to today's webinar on the topic, A Changing Healthcare Landscape, Succeeding with Real-Time Data Insights with Dr. Drumil Shah, CMIO at Compass Medical. As provider organizations have been challenged over the last few months with responding to patient care needs and adapting to dramatically different financial realities brought on by the COVID-19 pandemic, it's our goal today to discuss how providers can overcome these challenges to improve patient experience and access, drive financial results and organizational outcomes, and ultimately position themselves to succeed within what I think we'd all agree is a rapidly shifting healthcare landscape. So thank you all for taking the time to join us. Before we dive into today's conversation, I just want to cover a couple really quick technical logistics. So first of all, attendees will remain muted throughout the webinar. We will have a Q&A portion at the end of the presentation where attendees will be able to submit any questions that you may have via the GoToWebinar panel simply by clicking the question icon on the right-hand side of the screen. We will try to answer as many of the questions as possible during the session, and our team will most certainly follow up with any of you whose questions may have been missed. Lastly, a copy of the webinar recording will be sent to all of you after the presentation, along with a copy of the presentation slides that we'll be reviewing today. So with that said, I'm pleased to introduce our speakers today. First of all, our guest speaker, Dr. Drumil Shah. Dr. Shah is the Chief Medical Information Officer at Compass Medical PC, an independent provider-led organization in southeastern Massachusetts. Dr. Shah received his family medicine training at the New Jersey Medical School and subsequently graduated from the University of Illinois, Chicago, completing his postmaster's in health informatics. Dr. Shah also leads the Greater Boston chapter of the Society of Physician Entrepreneurs, or SOAP. Also with us today is Natalie Sheehan, Product Marketing Manager here at Patient Ping. Before joining Patient Ping, Natalie held marketing roles at both Biogen and Oxford Immunotech. Natalie holds an MBA from the Boston College Carroll Graduate School of Management and a BS from the University of Massachusetts Amherst. So with that, I'll hand things off to Natalie to get us started.
Thank you, Bobby, and hello, everyone. Thank you again for joining us today. I'm extremely excited to be speaking today with Dr. Shah from Compass Medical. Compass Medical is an independent, provider-led, multi-specialty medical organization in Massachusetts, and like most other medical organizations, has been significantly impacted by COVID-19 over the past several months. We'll be speaking today with Dr. Shah about the challenges his organization has faced, adapting telehealth technologies and strategies Compass Medical is using to increase appointment rates, and his organization's long-term plan for using real-time insights to successfully manage access, capacity, and throughput. As you all know, COVID-19 has significantly impacted providers across the entire care continuum, as well as our everyday life. Nearly 90 days ago, in mid-March, outpatient provider organizations saw visit volumes decline by close to 60%, leading to significant financial losses, operational strain, and patients not receiving preventative or sometimes critical care. In response to stay-at-home orders and urgent needs for healthcare access, CMS and commercial payers waived many of the reimbursement requirements for telehealth visits, reimbursing virtual visits at the same rate as live appointments for a wide set of visit types. Many provider organizations are now leveraging telehealth technologies to provide critical care for patients, but in many cases, telehealth appointment volumes have not been sufficient to offset the significant decline in overall appointment volumes and reimbursement. With that being said, I now want to turn the discussion to Dr. Shah to further discuss these dynamics that both Compass Medical as well as many other provider organizations have been navigating. Hi, Dr. Shah, and thank you for joining us today. Can you start out by telling us a little bit about your organization and the impact that you have felt from COVID-19 thus far?
Thank you, Natalie, for a great introduction. And let me take this opportunity, and on behalf of my team at Compass Medical, I would like to thank the Patient Ping team for this invitation. As you already covered, Compass Medical is a provider-led organization in Southeast Massachusetts. We are about 6 clinical practice sites where we have roughly 90 plus healthcare providers. Half of them are primary care physicians, and rest are non-physician providers. We include about 550 plus team members who work in various of these 6 facilities, and we take care of around 80,000 population in our surrounding communities. And we have been here since 1993. Next slide. So when it comes to impact of COVID-19, the best way I can describe the impact which all of us have felt is like an aftermath of going through a perfect tsunami, especially in healthcare, where capacity, access, and throughput, all 3 of the essential pillars of healthcare collided and almost on the verge of collapsing with COVID-19 uncertainty. About 90 days ago, the healthcare was challenged on all these 3 fronts. As it relates to the capacity management, one of the very first thing we observed is the fear of proximity. What I mean by that is patients feared coming to the healthcare facilities, healthcare providers feared taking care of the patients, and vice versa. And we also saw, which we have not really been trained in medical school, which is the safety standards and clinical standards were at odds. We had the rapidly evolving CDC guidelines and guidance from WHO for public health, and many of the medical offices and healthcare facilities were literally increasing their capacity on the fly while trying to meet the demands of the existing medical necessities. So what we observed also is a lot of the appointment slots were being left empty, yet we were not able to meet the demands of our patients because the triage volume for the phone calls were rapidly through the roof. And we were not able to somehow capture a lot of those phone call appointments into creating an appointment, partly because we, like many other healthcare providers, did not have telemedicine up and working. Thankfully, we were part of the initiative with Massachusetts Medical Society, where we have been preparing for telehealth for quite some time. It came to a virtue that we rapidly deployed telemedicine. The second aspect of the impact of COVID-19 relates to access. Many of our neighbors and surrounding provider groups literally ended up closing their doors with COVID-19 and completely became virtual. We, on the other hand, thanks to our operational team, were able to restrict the access to our front door. We did not close many of our departments except for select few, and we were able to start screening the patients and getting them through the right care at the right time. Traditional access points were ultimately became not relevant anymore, such as walk-in appointments, where think of the past overnight suddenly for our urgent care clinics. Same thing with the primary care and the specialty suites. Our waiting rooms became empty, and we had to suddenly scramble to create digital access points and virtual telehealth waiting rooms. So-called digital front door became a overnight reality for us without having any previous significant experience doing that. This third pillar, which also became quite challenging for the industry, including us, was the workforce dynamics and safety around it, which is what we call throughput. How do you take your existing financial projections and add your clinical endpoints and financial endpoints and create a forecasting which can help you keep your doors open for next 3 to 9 months, let alone years to come? And just like many of these surrounding providers, we also implemented telemedicine and started to redesign the team. We also were challenged with creating standards of care on the fly, because COVID-19 is not like any other infection we have been trained to operationalize a healthcare supply chain with. So while we had crisis with the access and capacity, we also needed to manage the team and the throughput from every clinician and every business unit. Back to you, Natalie.
Thanks, Dr. Shah. I'm sure many people listening right now can relate to the dynamics that you just described. And I like the way you're framing these three crises as capacity, access, and throughput. Now that it's been roughly 90 days since COVID-19 really first started affecting us, can you share a bit more about what Compass Medical has been doing in response to the challenges over the past few months?
Absolutely. And I would like to stay on this slide and explain some of the challenges we overcame by implementing some of the mitigating factors. So staying along with the capacity crisis, as I mentioned earlier, the fear of proximity, we implemented a detect, protect, and respond program where we literally started to educate our staff, our providers, and our patients. And simple programs such as Ask Before Mask, which literally means that we implemented a screening questionnaire right from the CDC at every touch point for the patient access. Next slide. Some of the other things we also implemented is multiple weekly provider meetings and updates we started to do to educate the providers on ever-changing scientific guidelines, which were coming literally day by day from CDC and WHO at times. We also started to build the bridge between our facility and surrounding community-based care models, whether it is surrounding local hospitals which are doing COVID-19 drive-through testing, or we creating the COVID-19 testing facility and then coordinating the care before patient needed to be transferred to a specialty clinic or patient getting discharged from the hospital. We implemented some of the clinical phone triage management processes and workflows in place, where we had the focus of providing good clinical care at the heart, but at the same time, as soon as we implemented telehealth, we tried to capitalize on many of the phone triage processes to create either a virtual check-in or the audio or video telehealth appointments. As many of us can recall, back in April, we had little to no guidance in the early April regarding audio reimbursement, let alone some of the phone triage. But we implemented triage protocols and started to provide audio triage through our physicians and providers. And thankfully, as the reimbursement landscape changed in the later part of the April, we started to see the return on investment for these phone triage processes. When it comes to access management, rather than closing the doors of our offices, we felt like it is very important for us to do our part. Otherwise, if all the ambulatory practices starts to go 100% virtual, it will increase the stress on local hospitals. So our local hospitals became the ally for us, and more so, we became the asset to local hospitals where they did not have to worry about any patients walking in, at least from Compass, without having some point of touch point with Compass provider. We also implemented small incremental innovations such as urgent care chat, where patient could simply text a number during regular office hours from extended hours in the evening and chat with one of our urgent care triage staff member, which gave the patients the access to telehealth and on-call provider far more intuitively than having to worry about calling the answering service and not knowing what's going to happen next. We are also looking at expanding our digital footprint. So as you can see on this slide, what we are all experiencing today is how is the future going to take the in-person care, which was pretty much 90% of majority of the healthcare facilities reality, suddenly overnight got challenged, and 80 to 90% of the care we provided in the month of April was virtual. How do you go from complete shift from in-person to virtual and find the new balance? And while trying to find the new balance, you also have to provide some of this innovative care models such as remote monitoring, chatbots, e-consultation, and none of the past foundational care management pillars have gone away. We still have to provide the acute and chronic care, preventive care, on top of the end of life and some of the other care coordination activities. So the best way to describe how we manage this is literally putting the team together who has done this well year after year with previous operational or financial or clinical priorities, and put them together and task them to do more with less resources. That is the reality we all faced throughout the industry, that we all were tasked to do more with less, including ICU capacity to healthcare provider capacity as an outpatient. And literally, to me, it feels as if the healthcare provider and patients were suddenly taken apart from each other and left to the chaos which needed to figure out itself. And that's how we figured it out. And I'll be more than happy to go over details in the Q&A sections. Back to you, Natalie.
Thank you, Dr. Shah. Clearly, Compass Medical has been really quick to innovate and adapt new technologies, processes, and overall strategy for care delivery in the past 90 days. It's really impressive what you've been able to accomplish in response to the COVID-19 crisis and the speed at which you've been able to do so. As we look towards the future, what do you expect to be the lasting impact of COVID-19 on healthcare delivery, and how are you and your organization thinking about potential long-term shifts in capacity, access, and throughput?
I think that's a great question. I think before I talk about what we are thinking at Compass, I think it's really important for all of us to reflect that the impact of COVID-19, especially with recent changes in regulation, consumer behavior, i.e. patient behavior, health and safety considerations for all of us as a community, and the economic downturn has created the provider landscape, which is going to be continuous in flux. What I mean by that is we have already seen massive amount of merger and acquisitions in larger systems over last 5 to 7 years. And I suspect that shift is going to continue in probably in a little bit of different direction, but provider landscape is going to continue to evolve as we see it. And the other thing is the consumer behavior, the patient behavior is suddenly overnight different, but not as drastic as we initially thought in the month of April, that no one would like to come back to the healthcare facility unless it's an absolute necessity, which is what we are seeing somewhat today, that in a recent article, United Healthcare suggested that their members are accessing telehealth for convenience now, especially towards the downward slope of the pandemic rather than medical necessity, because it's extremely difficult to measure the medical necessity and who needs to be seen virtually versus in person just by the pure reimbursement metric. Next slide. So here at Compass Medical, the way we see the future unfolding for us is best way to describe that is in terms of where the patients are when they are not in front of us. And this is the realization we had for quite a few years. And part of that is why we implemented remote care services such as chronic care management. And a couple of years ago, we also started to do in small pockets of providers transition of care management, which requires an intake from a clinical staff member when a patient gets out of the hospital or an inpatient facility or observation. So as we already had the experience doing some of these remote care services, back in April, we realized that what we don't know is what we need to get access to. What I mean by that is when the patient was in front of us in the exam room back in January, February, and March, up until the pandemic hit, we had a good understanding on the utilization of the patient that we know of at the time of the interview. But as the April came about and the volume of visits drastically reduced for us, including the entire New England, I think the volume reduced around 60 to 70% in New England last time I checked the statistics. It became very evident to figure out where are these patients besides being at home, because COVID-19 distilled the fear in the community, but that didn't stop the heart attacks from happening. It didn't start the new era where diabetes went away or the COPD exacerbation went away. So a lot of the medical chronic illnesses and acute on chronic conditions were still there. Preventive needs were still there. But purely because of the fear, the patients were not coming through the front door, literally the physical front door. And we started to realize that there is a big void for us getting the access to where the patients are ending up if they are not in front of us. And this is where we implemented the patient paying use case. And as you can see on this slide, immediately we enrolled our entire population, which is roughly around 80,000 population. We started to see the tsunami of data coming to us from roughly about 320 to 350 ER discharges a week since January till now. We did not realize up until we opened this floodgate of data that our patients are going through the emergency room this much. You may anecdotally know about a fax coming or someone calling you from the hospital, or maybe standalone ADD interface you may have from your hospital, a very specific facility and very specific number of discharges coming from that facility. But when you look at the population at large and look at all your surrounding hospitals, all your surrounding emergency rooms and facility, it gives you a perspective of what truly the risk you are managing, whether you are a fee-for-service entity or you are a value-based entity. So we started to see the ER discharges, observation, inpatient admits, SNF discharges, and home health admissions all coming through various aspects of the patient paying feed. And what we literally started to do with our team, as rudimentary as it sounds, we literally took some of this data into Excel and started to track and build some of the use cases. Some of the use cases started from a clinical standpoint and then ended up becoming a business use case. And some started from a business driver and got the clinical soundness built into it as we started to develop workflow, engage the team members, and started to look at what are the bare minimum tools and technology we need to capture this clinical event. As you can see on the left side, all of these events are clinical events. As much as we put the use cases of business around TCM or ER follow-up or telehealth to generate revenue, financial insights are really helpful. But what it comes down to is providing the right care to the right patient at the right time. And we started to take this data insights matrix from real-time alerts from patient ping and started to filter through which patient belongs in which clinical and business use case. Should an ER follow-up for, let's say, acute bronchitis be seen in the office for a physical appointment? One would argue no, that acute bronchitis patient could have gotten a virtual visit from a clinical provider, nurse practitioner, or a physician, and we can perhaps prevent a hospitalization by managing their underlying asthma or COPD better by adjusting medications or some of the other medical interventions which may be appropriate. Versus a patient who just got out of the hospital with CHF and a pneumonia with atrial fibrillation new onset may not be an appropriate candidate for virtual visit at all, but perhaps a virtual check-in followed by an in-person appointment and a care coordination via transition of care management intake through a nurse is a proper way to get that patient in front of their primary care physician or primary care team member to get the care what we refer to as comprehensivist. So these are the three models we are looking into for the future, the virtual first model, an in-person visit first model, and also somewhere in between utilizing care coordination and remote care services to the best of the ability we can to funnel the appropriate clinical use case with the business pillar we have available for patient access management. Back to you, Natalie.
Thank you, Dr. Shah, for sharing all of that. One thing I did want to, in addition, ask about that is you walked through all of the sort of compelling ways that your organization has been thinking about using the patient ping data and integrating it into your overall practice workflows. Are you able to share any of the sort of outputs of data on either your telehealth visits and any impact on telehealth visits or TCM visits specifically as it relates to patient ping?
Yes, absolutely. I think if you don't mind going to the next slide.
Yep.
This slide highlights the crux of what we all felt. Back in March 7th is our baseline, as you can see on the left side. This is the data which represents all of our primary care completed appointments week by week since March 7th till as of last week. So our baseline volume was somewhere around 3,000 appointments completed in primary care units a week, given the large size of primary care practice we have. And as you can see, we had almost 55% reduction as soon as the pandemic hit. And back in March and beginning of April, for a moment, if you take this blue and the gray shaded bar away, it will look like a drastic concave shaped curve where the volume of 607 in-person appointments in April 25th week is not something any practice can sustain the level of infrastructure and the team members you have to support a population such as 80,000 population we take care of. So if it wasn't for telehealth to come to the rescue, frankly, we were able to at least recover immediately from end of March to the April. And as you can see now, fast forward in the month of May and June, our in-person appointments are going back to somewhat 70% close to the previous capacity. And we still, thankfully, haven't given up on the idea of telemedicine, because we do think telemedicine was a virtue by disguise when it came to pandemic and helping us recover the appointment volume. We also believe that it is not going to be an easy workflow integration and the success unless you improve the experience for the patient and the provider and the team member. So while as of last week, our volume for telehealth is quite significantly lower than what it was back in April, we are fairly confident that in the months to come, we will continue to see the rise of the telehealth adoption, and perhaps by not much reducing the in-person volume and actually increasing the total capacity instead of rebalancing the capacity. If you don't mind going to the next slide. And this is the slide which highlights the crux of what we did with the real-time data insights as it relates to one of the care management program called TCM. Since January till March, we roughly did around 70 to 90 TCM work RVUs a month. And as you can see in the month of April, every single volume, not only the in-person appointments for regular visits, but the TCM appointments volume also went down. And there was a time in April where we did only roughly about 29 or 30 TCM appointments. And as soon as we implemented telehealth and started to open the floodgate of real-time data insights through patient ping feeds, We also did the team redesign where we took some of this work away from the physicians and centralized this with the care management team. As you can see here, in the month of May, we drastically improved from what seemed to be a dying program in April, suddenly became a forefront of our future planning. And we ended up with the month of May somewhere around 358 TCM completed RVUs. And we are on the verge of continuing to beat that baseline from the May in the month of June so far. And while the patient ping implementation is definitely one of the key catalysts for us, I do want to underscore the importance of the data without insights is useless. What I mean by that is you need to have the care team and the operational ability. So a lot of this success goes to my operational team and the clinical providers. I cannot take any credit. But the fundament of creating insights is you need to have access to data. So without patient ping, I can truly say that this kind of insights could not have happened because we just did not have any means to build ADT interface with 7 local hospitals and 3 different electronic healthcare record systems. It would have taken me months to build those interfaces, even if that's were to be deemed appropriate from a business standpoint. So it was nice to have that data insights overnight the moment we uploaded the roster, the data coming in. But at the same time, it is very important to have the team member who can take those data feeds and turn it into insights into action plan. Back to you, Natalie.
Thank you, Dr. Shah. Thank you for walking us through all of the amazing strategies and data that the data that you're presenting right now thus far. It's definitely really compelling data and really impressive strategies you've been able to implement. Want to give a quick reminder to folks on the line to please chat your questions as you have any. But before we jump into questions, we'll provide a bit more on patient ping and how we're able to partner with provider organizations like Compass Medical to provide the right data at the right time to inform those actionable insights. So Patient Ping is the nation's leading ADT network and real-time care coordination platform. Our network includes data from more than 5,000 post-acute facilities, 300 physician organizations, and over 1,000 hospitals. We connect providers across the entire care continuum to enable seamless care transitions through the community. Knowing where patients are in real time enables providers to thrive in both fee-for-service and value-based care environments and ensures patients are receiving critical care when they need it. For provider organizations like Compass Medical, our real-time event notifications enable our partners to maximize TCM appointments and billing opportunities, as well as ED follow-up appointments. This is enabled by a real-time ping, indicating that a patient has been admitted, transferred, or discharged from a facility. Users can then view relevant diagnosis information and up-to-date contact information for that patient, enabling timely and contextualized follow-up to schedule applicable outpatient appointments. Additionally, Patient Ping recently rolled out flagging for COVID-19 patients, enabling providers to identify COVID-19 positive patients in real time for prioritized outreach. Patient Ping also enables provider organizations to minimize avoidable hospitalizations and readmissions, reduce acute and SNF length of stay for ACO patients, and improve patient retention through visibility of referral patterns post-discharge. So that's just a bit about Patient Ping, and we'll be providing you with more resources for where to learn more. But with that, this concludes the discussion portion of the webinar, and I'm going to hand things back over to Bobby to begin our Q&A session.
Absolutely. Thank you so much, Natalie, and thank you, Dr. Shah, as well for the insights. We have had quite a few questions come through so far, but I do want to encourage folks to submit your questions as we go through, because we do have a few minutes here to have Natalie, Dr. Shah, and myself address those questions. I'd first of all just like to point out some additional resources that everyone has the opportunity to take advantage of following this presentation. So first of all, to learn more about Patient Ping, you can feel free to visit us at www.patientping.com, or you can contact us at connect@patientping.com. Additionally, you also have the opportunity to visit our ACO and physician organization pages for further details on Patient Ping's solutions and offerings for ACOs and POs. And we also have a resource page for COVID-19 to learn about Patient Ping's COVID-19 flagging capabilities. So we've gone ahead and provided these additional resources in the appendix, which will be in the slide deck that you receive following the presentation. So with that, we'll go ahead and jump into the Q&A portion, which again will be answered by Dr. Shah, Natalie, and myself. So question one that we have here is for you, Dr. Shah. And that question is, as your organization is considering forward-looking care delivery strategies, how are you factoring in the evolving but uncertain long-term reimbursement dynamics for telehealth care?
Thank you, Bobby, for a great question. I think when it comes to telehealth, as many of the skeptics of telehealth have been lately talking about, this is only during the pandemic and telehealth is going to go away, or it will never be able to make an impact on the quality of the care or reduce total medical expense. One thing is pretty clear, that every single stakeholder in healthcare, you look at whether it is our political landscape or regulatory landscape or payers, they have already started to make the changes which are permanent beyond pandemic. Some of the private payers throughout the nation have already included telehealth as their permanent policy. And even the bipartisan body today, in fact, put a bill in front of the stakeholders to make the changes in telehealth permanent. So now what I believe, whether these changes will be permanent or not, I do believe because of COVID-19 uncertainty, and unless we live in the world where vaccination exists and a mass adoption of vaccination for COVID-19 is already underway, we are going to see the surge of COVID-19 coming back, if not now, in a couple of months to next year. We never know, but whenever that surge comes in, hopefully we will not be as unprepared as we were back in March and April. So telehealth is an asset for any organization and a provider today who is looking to avoid the situation coming back again in next 2 years like it happened in March and April. One thing which is pretty evident even through my discussion with Dr. Joe Cuedar, who is the current president of American Telehealth Association and comes from Partners Healthcare, we strongly believe that some of the parity which exists today are likely to go away. So this is an anecdote and the opinion from some of the subject matter experts that audio visit parity may not last beyond the pandemic. What I mean by that is today we are able to do an E&M visit for majority of the payers through the audio means, 99213 and 99214, one of the most common E&M utilized by provider organizations. While it is feasible to accommodate that from a payer standpoint during the pandemic, but fast forward a year or two, that audio parity is going to be pulled back somehow, maybe not completely, but somehow it is going to be pulled back to a certain extent. We don't know how and what, but the video parity is here to stay. So we strongly believe at Compass, and I personally also, that video parity throughout the nation, especially for major payers, is here to stay. And what we are likely to see is some of the interstate regulations which were uplifted by a provider being in state A, able to provide care in state B. Those changes may also be restricted due to the licensure related challenges. But as far as the future of regulatory landscape is concerned, we feel strongly that telehealth parity is here to stay for video. And the other thing which we are likely not to see at a larger scale up until next few months, but we are seeing an upsurge or an uptick of a lot of digital health solution implementation in healthcare, whether it is a AI chatbot for patient triage or access management or online appointment access or digital marketing, or as simple things as just wayfinding for larger enterprises. So we are seeing digital health solutions being implemented all across the healthcare for various means and business cases. We at Compass are mainly prioritizing the care enabled by technology and care innovations through data insights. So remote patient monitoring, chronic care management, transition of care management, principal care management, and I can go on and on with all these acronyms. These programs existed and be reimbursable before COVID-19, which is a quite misnomer in the industry. A lot of providers think that all of these new reimbursement models are going to go away after COVID-19. But the fact of the matter is, a lot of this existed before COVID-19. So remote patient monitoring is not the new frontier. It exists for last couple of years. Regulations were modified earlier this year in January. What we are likely to see is a rapid adoption of these remote care services in months and years to come because of what the impact of COVID-19 has on the healthcare landscape overall.
Great, thanks, Dr. Shah. And as a follow-up to that question, acknowledging much of the uncertainty that's ahead of us, where do you foresee the ratio of in-person to telehealth visits ending up?
That's definitely a difficult question, but I think if I were to make the best estimate, I would suggest what we are likely to see is a typical hype cycle scenario with any technology implementation. There is a big hype, rapid adoption happens in the beginning, and then the hype cycle dissipates, and then you gradually see the optimization and the utilization reaches maximum trough after 6 months to 2 years. So we are likely to see the same thing with telehealth, that for the next 2 to 3 months, depending on what part of the country you are in, one can argue that we are less and less likely to see any further complete lockdowns in any of the states in our country. But especially since the early rise of COVID-19 numbers in some of the states are indicating, we are likely to see patients shying away from coming to the medical facility. So as far as the predictions are concerned, where we are is, as I mentioned in the earlier slide, we are around 17 to 20% of our total volume being in person. What I likely to see happening is three things. One is the healthcare providers, especially primary care providers, are increasingly going to be tasked at becoming what we refer as comprehensivists. The acute, simple sick visits such as cough, cold, conjunctivitis, urinary tract infection, and so on will be provided at the convenience or the reimbursement help. What I mean by that is either a telehealth provided by a payer or an urgent care or a standalone after our on-call model from a primary care is going to be the primary means of getting the acute care. And primary cares are mainly going to be tasked to see the complicated high-risk population, frequent ER utilizers, patient who just got out of the hospital, someone who has recently been diagnosed with acute and chronic complications. And these are the patients which are going to require in-person appointments. So roughly 40 to 60% of the appointments, especially in healthcare provider organizations, primary care, are going to remain in person, as it should. And the rest of the 40 to 50% is going to be remote care, whether it is going to be a synchronous audio video visit or asynchronous care management model where you are engaging patients through remote patient monitoring or text-based triage or a medical chatbot, or you name it. There are digital health solutions which every organization is going to at least evaluate, if not implement, in next 6 months to 2 years, because telehealth is here to stay. And for you to optimize the telehealth adoption, one has to create a virtual care environment. We are seeing very innovative models across the nation where some of the emergency rooms are providing virtual ER services to the local community. There are completely virtual behavioral health models now, because some of this specialty has been adopting telehealth for many years, and we have a lot of lessons to learn from those specialty. And we had the same situation at Compass, that our behavioral health department was the first getting up and working and reaching their 100% capacity, in fact, more than 100% capacity with telehealth. So if you ask me, do I see behavioral health department going back into the exam room and doing in-person psychotherapy? Perhaps, but that model will be 70-30. If I were to guess, where 70% will remain virtual and 30% will be in person, especially for certain things like group visits. As far as some of the acute care model, like urgent care, we are likely to see 50-50, where 50% will become virtual and 50% will be in person, versus primary care, 60-70% will remain in person, because that model is changing to becoming a comprehensivist model. So that's how I see the mixture of virtual care and in-person care working together in various clinical settings.
That's great. And one more question that came through on that same thread for you, Dr. Shah. What are some of the strategies and maybe also some of the challenges that your organization has faced and has used to encourage patient adoption and comfort with some of those virtual care modules, particularly around CCM and transitional care management?
Yeah, I think that's definitely a community by community dynamics which plays a role into this. So as it relates to the care management program, one piece of advice I'll give is, if you are implementing any care management services and you want to have those services be complementary to your in-person care model or care delivery, you don't want to put everything into one big process and hope that it's going to iron out itself. What I mean by that is, have dedicated resources, put the best foot forward, because just like everything else, we get the first impression to the patient only one time. And if you end up getting the patient starting on a care management program with a negative or a bad experience, they are less likely to continue and spread the message across their own community. So what we have done is care management, CCM, when we implemented, we took literally 4 to 6 months, as far as I can remember, probably more than that, in designing the workflows, figuring out the financial insights into pro forma development, and hiring the resources before we actually engage with the patient. Because engaging with the patient comes at the later stage of the project deployment. And if you're thinking about doing this when patient comes into the office, we'll enroll patient in the program, and one of the staff member who happens to have 7 other responsibilities will continue to do this program on top of what they do, that program is going to suffer drastically. And it will become challenging for you to scale, and it will become extremely frustrating for the patients to get the value out of the program. Because some of the perception for the patient is CCM is just a telephonic medicine. So you called me before, and now you're going to call me regularly. Why are you charging me? So there are a lot of misconception for the patient, which requires front loading the education and training for the patient, that these programs are designed for chronic disease management. This is not a triage program. This will be a proactive way of reaching out to the high-risk population, people who are vulnerable to hospital admission or someone who has a higher risk of readmission. So this is how we see the patient dynamics playing into a role. And we also encountered the same thing with telehealth. There are a lot of senior population and some of the socioeconomical and social determinants of health aspects where some of the patients don't have internet, let alone a smartphone. So what do you do in that case scenario? Guess what? At least they have a landline. And the parity with the audio visits back in April came as a lifeline to us because we were on the verge of rapidly deploying remote patient monitoring tool where we would buy the devices and 4G cellular service and give to those population, which we may still do because those are the patients who really need access to care, the person who doesn't have resources. And as you become a risk-bearing entity or even in a fee-for-service and you look at the return on investment, I highly suggest anyone interested in developing those care programs is to do a data analysis on your population and understand which 20% of your population are generating 80% of your total medical expense. It's not easy to find that population, but any starting point would be better than just guessing. And I think for us, aside from our EHR clinical data set, the patient ping data set became a really great insight for us to find those 20% high risk population right from the get-go.
That's great. And we did have a question come through for you, Natalie. The question is, you had alluded to a COVID-19 flagging capability. What criteria does Patient Ping use to identify COVID-19 patients, and what does that look like within Patient Ping?
Yeah, definitely. It's a great question. So in terms of the criteria used, the COVID flag is going to be applied to patients who've had clinical encounters on our network that involve specific COVID-19 diagnosis. That's either through a COVID-19 diagnosis with the actual diagnosis code for COVID, which is U07.1. Or it could also mean that it is a diagnosis that includes free text mention of either COVID or COVID-like terms, so coronavirus, different terms like that, and one of the other CDC suggested diagnosis codes for COVID as well. So it's going to be based on that criteria, and what it actually looks like in the platform is it's actually a flag that is put on the different patients that are applicable for it, and you can actually filter as well within our Patient Ping feed to only show patients that have been assigned that COVID flag.
That's great. Thanks, Natalie. And we do only have time for one more question here. And so for any that we didn't have a chance to address, we'll go ahead and make sure that we follow up with folks on those. But Dr. Shah, we did have a specific question come through for you related to some of the data that you presented earlier. And the question is, are your work RVUs associated with virtual clinician visits, APP and MDs, or nurse telephone calls?
So the way RVUs are attached is RVUs are linked to a CPT code. And the way it works is for nurse practitioners, PAs, and physicians, they are considered what we call qualified healthcare professionals. So they can provide an E&M services, whether it is 99213 and 99214 or a 99491, for an example, which is a CCM 30-minute services provided by a QHP, which is a nurse practitioner, PA, or a physician. So all those CPT codes have an RVU versus the other CPT codes such as 99490, which is a specific CPT for chronic care management or any of the home health agency and remote patient monitoring and the other care management CPT codes are usually an increment of time spent by clinical staff, which you have to track and measure for audit purpose. And at the end of the month, you bill for that clinical time on behalf of the clinical staff. but even those CPT codes are billed under a billable provider. So none of the RVUs are linked to any nurse or medical assistant. They do the work of providing care management and care coordination, but at the end, there is always a requirement of either a direct supervision of clinical activity, such as in case of chronic care management program, or a general supervision responsibility, such as in case of home health agency and remote patient monitoring, which falls on to billing provider. So ultimately, you do need a physician and or a nurse practitioner as a qualified healthcare professional to bill any RVU. I'm not aware of RVUs being billed under, at least in the outpatient primary care setting, under clinical staff themselves without a billing provider.
That's great. Thanks so much for the insight. And just to wrap us up here, I want to again thank both Natalie and you, Dr. Shah, for joining us today and providing such a thoughtful discussion. And importantly, I just want to extend our gratitude to all of you who took the time to join us this afternoon. We really hope you found the discussion helpful. Our team will be following up with you again with a copy of the presentation and a recording. But again, please don't hesitate to reach out to us if our team can answer any additional questions for you, or if you're interested in learning more about Patient Ping, more about Compass Medical's experience over the last few months and moving forward. Thank you again, and we hope you all have a wonderful rest of your day.
Thank you.